Musculoskeletal problems are everywhere. They make up almost a third of GP consultations, and yet study after study show that medical students and even young doctors feel less confident in this area. Most of us get fewer than 60 hours of musculoskeletal teaching in medical school, and a lot of that's just learning anatomy. But orthopaedics is so much more than bones on x-rays. It's about pain, stiffness, function, and more importantly, quality of life. In today's episode, we're going to step back and look at the big picture. What actually is orthopaedics? How we make the diagnosis and the major ways patients present. We'll then touch on the wider team involved in the care and finish with the orthopaedic emergencies you must never miss. Think of this as a mind map of orthopaedics, a framework you can use whether you're a student, a GP, or just someone keen to understand better about this specialty. So let's grab a coffee and let's walk through the orthopaedic mind map together. Good day and welcome to Aussie MedEd, the Australian medical education podcast, designed with a pragmatic approach to medical conditions by interviewing specialists in the medical field. I'm Gavin Nimon, an orthopaedic surgeon based in Adelaide, and I'm broadcasting from Ghanaland. I'd like to remind you that this podcast is available on all podcast players and is also available as a video version on YouTube. I'd also like to remind you that if you enjoy this podcast, please subscribe or leave a review or give us a thumbs up, as I really appreciate the support and it helps the channel grow. I'd like to start the podcast by acknowledging the traditional owners of the land on which this podcast is produced, the Kaurna people, and pay my respects to the elders both past, present and emerging. I'd like to remind you that all the information presented today is just one opinion and that there are numerous ways of treating all medical conditions. It's just general advice and may vary depending on the region in which you are practicing or being treated. The information may not be appropriate for your situation or health condition, and you should always seek the advice from your health professional in the area in which you live. What is orthopaedics? Well, orthopaedics deals with the musculoskeletal system, bones, joints, muscles, ligaments, tendons and nerves. But it's not just about the bones, it's about function and movement. It's about restoring quality of life, whether you're a tradie getting back on the side after a fracture, an athlete returning to play after a ligament injury, or an older person wanting to walk pain-free to the shops. That's what we look after. We see patients across the entire lifespan, from newborns with congenital problems to elderly patients with arthritis and fractures. And importantly, orthopaedic surgeons aren't only just surgeons. Sometimes we operate, yes, but often we manage conditions conservatively with therapy, rehab, or even injections. So let's start with diagnosis. Well, the way we diagnose always starts with a history, the story the patient tells us, and that story is usually built around symptoms. Let's go through those key symptoms categories one by one. Remember, the diagnosis is often what makes the history, while the examination helps us confirm the diagnosis, and the investigations, while adding to the diagnosis confirmation, they can be used for staging so as to determine treatment options and determine prognosis. So the first symptoms that patients may present with is pain. It's the most common reason patients see us. But not all pain is equal. Mechanical pain is a pain of wear and tear. Think of osteoarthritis or disc degeneration. It worsens with activity and it settles with rest. It can also come on from instability like a torn ligament or from impingement syndromes in the shoulder or in the hip. Inflammatory pain is somewhat different. This is worse in the morning, often with stiffness, lasting more than half an hour, and improves as the patient gets moving. It's typical of autoimmune and inflammatory arthropathies, but also crystal arthritis like gout and Shido gout, or even inflammatory tendonitis and bursitis. Traumatic pain can be either acute from fractures, dislocations or ligament injuries, or chronic from poorly healed fractures, malunions, non-unions, or even getting post-traumatic arthritis. In some cases, it progresses to complex regional pain syndrome. This is where the pain is out of proportion to the injury. Infection is always on the list of causing pain. Septic arthritis or osteomyelitis can present with acute pain and with systemic illness as well. Whilst neoplasms, they can cause deep, unrelenting, often night pain, not relieved by rest. Nerve entrapment, however, is often a good cause of pain, and that's a burning, shooting, electric type pain, and with classic examples being things like sciatica or cervical radiculopathy, very painful conditions, or even peripheral nerve entrapments like carpal tunnel or cubital tunnel syndromes. So when a patient says, look doc, I've got a lot of pain, we're already sorting through one of these sort of categories when we're assessing the patient. Aussie MedEd is supported by HealthShare. HealthShare is a digital health company that provides solutions for patients, GPs and specialists across Australia. Two of HealthShare's products are Better Consult a pre-consultation questionnaire that allows GPs to know a patient's agenda before the consult begins, as well as HealthShare's specialist referrals directory, a specialist and allied health directory helping GPs find the right specialist. Stiffness, however, can be just as disabling as pain. We can split this into articular causes of stiffness or periarticular causes. Stiffness secondary to articular causes is the stiffness that occurs from within inside the joint. The most common one is being osteoarthritis, with the bony spurs and the loose bodies jamming in the joint, but also with the capsular tightness that occurs around the joint associated with this. Meniscal tears can also cause a locking type sensation in the knee, for instance, and that can cause stiffness secondary to a locked knee, whilst fluid in the knee with big effusions can cause filling of the joint and therefore stiffness secondary to that. And one of the most common causes of an intra-articular stiffness is the adhesive capsulitis or frozen shoulder, with stiffness associated with that, usually presenting after severe pain. Post-infective arthritis is another cause of stiffness where the joint gets scarred and bound down. Periarticular causes, however, come from outside the joint. These are muscle contractures either from scarring or from neurological conditions, often in the case. Tendon adhesions or shortening can also lead to stiffness, as can ligament contractures, and capsular fibrosis, as said before, is probably one of the most common causes, with osteoarthritis causing both the intra-articular stiffness as well as a capsular, almost extra-articular element to it as well. Heterotopic ossification after head trauma or after a significant bleed can also lead to stiffness, where bones formed where it shouldn't be developing. And soft tissue scarring around a joint can also lead to stiffness also. And even soft tissue tumours pressing on a joint can cause the symptoms of stiffness. So stiffness isn't just stiffness, it's a whole spectrum of underlying pathology. A third symptom that patients can present with is deformity. This can be dramatic or subtle. And again, we've got to think about articular versus periarticular causes. Articular causes include osteoarthritis, once again, with either, particularly in the knee, causing a varus or valgus deformity, in other words, it bows in or bows out. But fractures that heal crooked or in an abnormal plane can lead to deformity, such as a distal radial fracture with dorsal angulation can lead to a classic dinner fork deformity. And also congenital deformities can occur, like club foot or hip dysplasia of the hip. Also, infection destroying a joint or tumours distorting a joint or a bone can lead to deformity. Periarticular causes are causes that occur around the soft tissues around the joint or bone, and muscle contractures from scarring or neurological disease can lead to tendon shortening or adhesions, ligament contractures, capsular fibrosis, and again, that can lead to deformity. So really the question always is the deformity coming from the bone, the joint, or the soft tissues around it? One of those three structures. Again, obeying the rule of threes. Swelling is another common complaint, and the causes of this are many. Most of the swellings we see are traumatic and associated with fractures or soft tissue sprains, ligament injuries, contusions, or even dislocations if they're quite deformed. But you can get inflammation inside a joint causing swelling, and the classic causes of arthritis, either osteoarthritis or the inflammatory arthritis, can cause swelling themselves, along with crystalline depositions such as gout or pseudogout. And again, we've always got to remember infection, septic arthritis being a major issue. So someone presenting with acute painful swollen joint, septic arthritis needs to be excluded. And soft tissue swelling around the joint but not involving the joint could be from a cellulitis or an abscess, or even a bursitis, either septic or aseptic. There are other causes of swelling, though, that aren't quite classic of orthopaedics. You've got to think of things like deep vein thrombosis or lymphedema. And of course, in an acute traumatic scenario, such as a fractured tibia, you've got to think of a swollen leg secondary to the trauma, which can have an associated compartment syndrome. Slowly progressive swelling, it can be caused by a soft tissue or bone tumours as well. A generalised swelling, considered heart failure or renal or liver disease, can cause a scenario with that. Always, if someone develops swelling suddenly, particularly after they've been given a medication, you always got to think of an allergic or immunological response. So really the timing and distribution of the swelling really helps affect or determine what the diagnosis is and needs to be taken into account. The next presentation might be something like weakness, and this can be either genuine or apparent. The most common cause of weakness might relate to a neurological disorder, such as an upper motor neuron disease and a stroke
or spinal cord injury are probably the most serious scenarios in that situation. But you can get peripheral neuropathies leading to a muscular or radiculopathy leading to weakness, or even motor neuron disease. Again, you've got to think of other general symptoms like primary muscular disorders, muscular dystrophies, or metabolic myopathies, or drug-induced myopathies could be a factor of weakness. But probably in orthopaedics, one of the most common things that we would see for leading to weakness is disuse. And that might be secondary to immobilisation, either primarily caused by the use of a plaster to immobilise a limb whilst the bone is healing, or in the period after, say, shoulder surgery and they've been placed in a sling, or it could be secondary to the pain that's been caused by an orthopaedic condition leading to generalised weakness or muscle wasting. But you also get it in post-operative surgery, you can get weakness, and in the elderly you get sarcopenia, which can lead to weakness. Weakness can actually be secondary to loss of the actual motor power of the joint, and that can be either secondary to nerves, as we've outlined above, but also you've got to remember acute tendon ruptures can lead to weakness, as can obviously joint instability, where they get a sensation that the joint's going to pulsate or dislocate, and therefore they have an inhibition of movement. This also occurs in pain. When someone's got a pain around a joint, they don't like to push through it because it hurts. And of course, anything that causes inflammation causes weakness as well, secondary to the pain in that scenario. Finally, you've got to think about things like metabolic causes and endocrine causes causing weakness, such as thyroid disease or diabetes, or even electrolyte imbalances. So sorting through true weakness and apparent weakness is important. As an upper limb surgeon, one of the more common reasons a patient might present to me is from instability. Instability is not that hard to diagnose because often the patient feels like the shoulder or the joint they're talking about pops out of joint. They feel that it gives way or feels unstable. These traumatic causes are the most common scenarios where, as the joint is subjected to trauma, the ligaments disrupt around it, and in the shoulder it's the labrum that she tears, which is the thickening of the capsule. But you can get a traumatic cause of instability, and this can be related to constitutional causes, such as patients with generalised ligament laxity, therefore they've got a multidirectional instability, for instance, or they may have connective tissue disorders as well as part of this. There are congenital causes as well. One of the more common ones to think about is developmental dysplasia of the hip, where the newborn needs to be assessed to make sure the hip feels stable, and if not, needs to be immobilised so that the acetabulum develops around it. There are also skeletal dysplasias that can lead to deformities of the joints and therefore instability. Neuromuscular causes are another cause to think about, with muscle weakness and poor proprioception, muscle contractures, or even peripheral nerve injuries lead to slowly deforming joints and therefore a chronic type instability. And then again, after surgery, even including hip replacements, these joints can dislocate. Associated with rheumatoid arthritis and other inflammatory arthropathies, as well as crystalline arthropathies like gout, you can get stretching of the capsules, destruction of the joints and the ligaments around it, leading to instabilities. And in the rheumatoid disease, it's very common in the metacarpal phalangeal joints. Now, one of the lesser causes or presentations to an orthopaedic surgeon might be from neurological sensory deficit, but it's not that unusual in an upper limb surgeon, where we'll see symptoms of paresthesia, numbness or weakness in one of the nerves in the upper limb. The classic one being the carpal tunnel or cubital tunnel syndrome, but you can get it in the leg as well, around the upper thigh, called neuralgia paresthetica, where the lateral cutaneous nerve of the thigh gets contracted, or tarsal tunnel syndrome. Probably even more common than that is spinal root issues, such as a disc prolapse, or secondary to a spondylolisthesis, or secondary to degenerative arthritis. And that's pressing on the spinal nerve roots. That can cause a severe shooting pain down the leg. You must remember, though, when you see these neurological conditions, that the peripheral neuropathies can be general as well. And the most common scenario nowadays is diabetes, with the high sugar levels causing primary nerve damage. But you can also get it secondary to medications, particularly chemotherapy agents, as well as alcohol. And there are also hereditary causes where patients are more prone to nerve entrapments in general. Finally, traumatic scenarios can occur after direct trauma to the nerve, such as a stabbing or brachial plexus. Trauma stretching the nerves. There's also iatrogenic causes that can occur post-surgery, as well as the risk of compartment syndrome can lead to secondary nerve damage. In orthopaedics too, though, we must always remember other medical type causes, such as stroke, multiple sclerosis, and spinal cord tumours aren't out of the question as well. And then there's, unfortunately, we've got to keep a mind open to rarer but important scenarios such as the autoimmune type or inflammatory type conditions such as Guillain-Barré or vascular neuropathy, etc. So there's lots of causes of nerve issues to be aware of, and we need to take those into account when assessing a patient with a presentation with muscle weakness or sensory issues and presenting with a neurological type of thing. We always got to remember, however, after spinal injury, don't forget the significant and very important scenario of quarter equina syndrome, which can present with subtle reduction in perianal sensation and loss of urinary or bowel movements. And this can occur from a significant disc prolapse pushing on the spinal nerve roots.
I'd like to let you know that Aussie MedEd is sponsored by Avant, Medical Legal Indemnity Insurance. They tell me they offer holistic support to help the doctor practice safely and believe they have extensive cover that's continually evolving to meet your needs in the ever-changing regulatory environment. They have a specialist medical indemnity team located here in Australia and have access to medical legal experts 24/7 in emergencies.
Now, moving along to other symptoms that a patient may present with, well, congenital abnormalities are not uncommon to the group of paediatric orthopaedic surgeons. They bring their own spectrum of conditions. You've got to think of skeletal dysplasias, achondroplasia, or osteogenesis imperfecta can present in various presentations, or growth abnormalities. And you also get limb deficiencies, either transverse or longitudinal. And when it comes to the spine, you also get issues such as spina bifida or hemivertebrae, along with foot and ankle deformities such as club feet, tarsal coalitions, and upper limb scenarios like Sprengel's deformity. Along with all these things, you can get these connective tissue disorders, which we've touched about before, either as Danlos or Marfan syndromes as well. So these congenital abnormalities is an extra element to orthopaedics treatment, which is managed usually by specialist paediatric orthopaedic surgeons who specialise in these areas primarily, but in a general scenario, a lot of orthopaedic surgeons will have some experience with these as well. That brings me on to my final reason a patient may present to an orthopaedic surgeon is with a lump. And these can be what I describe as tumours and bone or soft tissue lesions. These can be divided up into benign bone tumours such as osteoid osteoma or osteoblastoma or enchondroma, which often are incidental findings on x-rays, or malignant bone tumours such as osteosarcoma or chondrosarcoma, or primary lymphoma of bone. We can also get soft tissue benign lesions such as lipomas, a lump in the fat which develops in the soft tissues and presents as a lump. You can get giant cell tumours or tendon sheaths. We can get malignant soft tissue tumours such as lipomas, synovial sarcomas, etc. And then there's tumour-like lesions, bone cysts, and metastatic disease, which is the secondary cancers that spread to the bone, breast, lung, prostate, kidney, and thyroid. And finishing off, systemic lesions like Paget's disease or hyperparathyroidism can present with bone deformities or lumps. One really useful way of thinking about orthopaedic problems also is to apply a surgical sieve, breaking these conditions down into acute, chronic, and mixed presentations. This is something I really emphasise when I'm teaching. It doesn't replace these categories and how patients present, but instead it gives you a time-based lens to look through. So if you look at acute presentations, these are sudden in onset, often dramatic. They're the classic reasons people turn up to the emergency department or to their GP with something they can't ignore. Well, if you look at the traumatic causes, fractures, dislocations, acute ligament ruptures, tendon tears, or meniscal injuries really fit into this area. But you can't forget things like infections such as septic arthritis. The key to this group is the acute problems present with urgency. The diagnosis may not be difficult to make, but the priority is acting quickly to prevent long-term disability. Chronic presentations, these are things that a patient might present to a GP or an orthopaedic clinic for. Degenerative conditions like arthritis or degenerative disc disease or rotator cuff degeneration really are the main conditions that present in this scenario. They present with gradual pain, they may present with stiffness, and they may present with deformity. Inflammatory disorders such as rheumatoid arthritis, gout, ankylosing spondylitis can also come on suddenly. They might have a flare-up, but they usually are slowly progressing but with intermittent flare-ups. Chronic conditions rarely require emergency intervention, but they're essential to what we do in orthopaedics, restoring movement, correcting deformity, and preserving independence. But amongst acute and chronic presentations, you get a mixed picture. This is where things overlap, where a long-standing condition suddenly tips into an acute event. These are often the most challenging because you have to deal with both the underlying pathology and the new complication. They're not that common, but scenarios might be a patient with osteoarthritis who suddenly develops a locked knee secondary to a loose fragment sitting inside the knee joint. Or there might be a metabolic bone disorder which suddenly leads to develop some malignancy. Or there may be avascular necrosis, which suddenly it's been simmering along for years but suddenly collapses secondary to the loss of bone structure, leading to acute pain and then development of secondary arthritis. Even congenital deformities such as scoliosis can suddenly accelerate or decompensate during growth spurts. So mixed cases remind us that time frames can overlap, and a patient may live with a condition for years, but the reason they seek help is the acute change that just occurred. So when you're faced with a new patient, you can think not just about the symptom, the pain, the stiffness, the deformity, the swelling, the weakness, the instability or neurological problem, but also what time course it was. Is it acute or is it chronic? This mental framework helps you triage urgency, choose investigations, and decide whether the problem is one for the emergency department or an orthopaedic outpatient. Once we've done an assessment looking into both their history and how they presented and the symptoms they presented with, we can go to examination. And in that process, we go down the path of the look, feel, move, and special test approach. We always look at posture, we look for scars and wasting and deformity, we feel for warmth around the joint, and we look for tenderness and swelling around the joint. We move the joint, we start with active motion and assist it with passive to see if that's greater, and then we use special tests to confirm our suspicions of what the diagnosis might be. Investigations are what follow after that. These help support our clinical impression. Don't forget bloods. We can check bloods looking for infection, inflammation, or metabolic disease. And then we proceed to imaging. I like to always think of plain x-rays first. You always want to consider and get so much information about a plain x-ray that they should never be excluded unless a particularly rare situation where it's not required. We then can move to ultrasound, CT or MRI depending on the problem. And of course up our sleeve we've got things like biopsies if we're worried particularly about a tumour or an unexplained lesion, although nowadays a lot of these biopsies are done by dedicated human services. That brings me up to the subdivision of orthopaedics. Orthopaedics today is becoming more highly specialised by region, spine, shoulder, elbow, hand, hip, knee, foot and ankle, and by patient group, paediatrics or adult, or condition, tumour, or trauma, or deformity correction. And this is not just the orthopaedic surgeon, of course, it's a team. Remember, orthopaedics is a team effort. Around the surgeon, there are anaesthetists, there's rheumatologists, radiologists, sports physician, physiotherapists, occupational therapists, rehab specialists, and sometimes neurosurgeons or oncologists. And at the centre, of course, is always the patient and their family, and also directed and orchestrated by the referring doctor, the general practitioner, or the emergency department, where it's a two-way street. Fine, let's move on to the orthopaedic emergency room. Let's never miss. Probably the most important one is the quarter equina syndrome, where back pain, secondary to a large disc prolapse, presses on the sacral nerve roots and can lead to urinary or bowel involvement and does require urgent decompression. Compartment syndrome, where the pain's out of proportion after a traumatic incident. The compartment swells up with fluid, puts pressure on the vessels feeding that compartment, reducing the circulation to that compartment and leading to increasing muscle damage and leading to secondary more pressure on the compartment. This requires urgent fasciotomy. Septic arthritis, as I said before, a hot, swollen, painful joint will require surgical washout and antibiotics. If not treated, it can lead to secondary arthritis and lead to stiffness. And open book fractures, where the pelvis has been damaged such that the pubic symphysis or the pubic rami, along with the sacroiliac joints, are damaged such that the whole pelvis splays open. This can lead to catastrophic blood loss, needing urgent stabilisation, and can be easily initially treated by pelvic binding, but often will require surgery, such as plating or an external fixator. And then, of course, there's things like compound fracture, an open fracture where the bone is sticking out through the soft tissues and requires antibiotic debridement, reduction, and stabilization. And the one that a lot of people aren't aware of is acute septic flexor tenosynovitis, where an infection in the tendon sheath in the hand leads to a localized compartment syndrome, as well as a lot of scarring, and if left, can lead to severe damage and it requires urgent surgical drainage. These are all time critical. Recognising them early, acting fast upon them can affect the outcome. So that's the orthopaedic framework. From how a patient presents, from pain, stiffness, deformity, swelling, weakness, instability, neurological symptoms, congenital conditions, or lesions, can help us guide us where we proceed with our examination, investigations, and which team is involved. As well as knowing how they present too. If they present with an acute or a traumatic event, or if it's a combination of the two. Combining these in assessing a patient, knowing the conditions that develop, and being aware of what help you've got around can really help guide you. And that's why knowing about the teamwork that makes up an orthopaedic team and also the emergencies not to miss, hopefully this gives you a little bit of information to take away and keep in the back of your mind. So if you take nothing else away, remember this. Orthopaedics is about restoring movement and function, and emergencies must never be ignored. Once again, thank you very much for listening to this podcast. I really hope you've enjoyed it. I've actually enclosed a mind map, which is attached to the website if you'd like to look at it, and it's also on the YouTube channel as well.
Thanks again for listening to the podcast, and please subscribe to the podcast for the next episode. Until then, please stay safe.